Joining me now on Waterloo Live is Mick Crumplin, retired surgeon and historian and author of Men of Steel, Surgery in the Napoleonic Wars, and co-author of Waterloo After the Glory. Mick, it's great to see you. Welcome to Waterloo Live.
Thank you.
What training did someone need to be part of the medical services in the British Army during this period?
Inevitably, it's going to be a haphazard and ill-organised and an ill-prepared education. But basically, the pattern seemed to be that after any form of schooling, be it private or public, an indentured apprentice would join his master at the age of about 15, and then for 3 to 5 years, usually either working for an apothecary physician or surgeon, would work for him, and then depending on his abilities and learning, he would then join a hospital, a regional or big hospital in a city or town, and walk the wards, attend lectures and dissections and anatomical examinations. And then he would be subjected to an examination, which was not that rigorous and fairly despotic, I would think, really. It was an oral exam only. The examiner, one of 10 in the Royal College of Surgeons in London or in Scotland, would ask what his training had been, and then he would fire questions, and the other 9 examiners would listen, and then you would get a response of pass or fail, and you could either take the certificate, military certificate, which was more common than the membership of the college, which may have been a more difficult exam. If you passed, you went to Berkeley Street, headquarters of the Army Medical Department. You may have been asked more questions about physic, and then appointed to be a regimental assistant surgeon, a warranted or commissioned hospital mate, or even, if you were very clever and had other assets, a full surgeon to a regiment. And then ideally you would, according particularly to John Hunter, to serve in hospital first, so that you got some idea of military and hospital and bigger diseases and more complex problem. And then you'd go out onto the field. And I think that is the most important thing in the training, that most of the good doctors we read about, and unfortunately it's only the good ones who write, or the famous ones who write, the learning curve was best achieved on the battlefield. And there was no substitute for that at all. He had to purchase his own instruments, although he was given drugs by the government. He had a mule or cart, and in England, we didn't really get a chair of military surgery until later on in the 19th century, although in Scotland in 1806, there was a Regius chair of military surgery. So inevitably, because life was cheaper north of the border, lots of military surgeons fled up to Edinburgh and Aberdeen and what have you for learning and preparation. So that really led to a pretty poor preparation for military campaign and surgical life in the army, but many men managed to get through it and do very well.
It's not exactly a training that fills you with confidence these days, for sure. Most casualties in armies during this period were, of course, due to disease rather than wounds sustained on a battlefield. What were the common ailments and how were they treated?
Well, of course, it depends on the climate, it depends where you are, it depends on the season and the prevailing problems where you're stationed. You can reckon that in most units there would be 30 to 40% sick at worst. And that meant that regimental surgeons had to know with their commanding officer how many fighting men were available and how many were not. Now, the diseases that were common were bowel infections. Diarrhea was very common. Dysentery with blood was more severe and probably accounted, although it was a fairly low mortality rate, for most deaths. The other problems were ill-defined. Nosology, or the classification of disease, was limited. Fevers of all sorts of diseases were recognized but ill-classified. Malaria, of course, as you can imagine, particularly benign tertian malaria, was easy enough. Large spleen, temporal episodes of rigors and so on. Typhus with its rash, yellow fever by jaundice and vomiting blood. Scurvy was pretty rare in the army, but it did occur with joints, bleeding gums. Bilharziasis in Egypt, there was a host of problems. And of course, ophthalmia, I forgot to mention, which was a real blight of the British Army, was actually the first disease to get a disability pension in the British Army. So there was a flurry of diseases that were ill recognized, except for a few. Continued fever was common, and that probably in the main was due to typhoid. But we don't know. And I mean, some common colds and pneumonias were obviously recognizable. And I think God cured most of these men because the treatments meted out by physicians and surgeons were not terribly useful, as you know. The antiphlogistic regimen of bleeding, catharsis, and emesis, low diet, and so forth. And just to mention, of course, alcohol and venereal disease, both were big scourges in the army at various points. And you cannot blame a soldier who's been womanless and alcohol-less for months and months for going into a town after seeing their mutilated friends from having a bad time. And that is an issue. The other disease that's worth mentioning is the Walcheren fever, which was a mixture of diseases, probably dysentery, typhoid, and particularly malaria. The commonest cause of discharge from the army was worn out, and therefore we mustn't forget rheumatic problems and joint diseases from the 6,000 to 7,000 miles that the average soldier would tramp across the peninsula. So there's a variety of the diseases, and they were managed pretty crudely and ineffectively.
So when it comes to the battlefield, then, how does casualty triage work? Did such a thing even exist?
Well, I think that triage did not exist. I really, Larrey does mention it, and people mention Larrey as being involved in it. And if you have a quiet time with a few casualties, of course you can sort them out go into a tent if you're walking wounded. You go into a dying tent if you're dying, and we'll sort out the ones who need urgent management. And those are the three categories, really. And today, if you collect the ones that need urgent treatment, they need continuous review because people go off and get worse suddenly and need to come up the queue. So it's a complex matter, and I don't really think it was well used then. The trouble is that officers and friendly casualties were often picked out in preference to NCOs and privates, and also, of course, enemy casualties came a bit last, and that's not terribly good thing. I think when enemy casualties got treated, they had reasonable management, but they were not put to the foremost. And there's no doubt that there being a lack of triage and facilities to go on a battlefield and clear out hundreds or thousands of wounded that had happened in one day is a challenge that even barely today we are faced with. So I don't think it was really practiced. There was a man in the Navy called Young, and he, in his ship, did sort out casualties in one battle, but he had a fairly constrained number of casualties to do that.
So in terms of the wounds, what's the most common, well, what are the most common wounds, and how are they treated?
Yeah, most soldiers presented to their surgeons with limb injuries because the torso and head and neck wounds were often fatal and less common. And it's interesting that the leg wounds were often twice or three times as common as arm wounds because they do actually present a much bigger surface area. Many shots are dropping. A lot of wounded men were hit by spent rounds, which were also deflected or slowed down, or by distance or imparted less energy. And these, so the commonest cause of injury was small arms fire, undoubtedly muskets mainly, carbines, pistols, and so on. Different in the Navy, there you have heavy ordnance, which throws off shards of impregnated jagged oak, and second in the army to small arms fire the cause would be ordnance fire as well. But the only way of surviving an ordnance strike is a tangential shot or a limb avulsion or limb shot. And I don't know, I've often discussed this with Patrick Mercer, but I think if you look at the surviving people, because no one's done a dead battle count, that's what you really need to know cause of death. It's probably small arms fire mainly. And the surgeon would put the patient often in the position that he received the injury if it was difficult to find, digitally explore the wound, enlarge it, remove the musket ball, and most importantly, any porous material that was thrust into the wound to, because bacteria were in the interstices of these things. Then sword and lance and spontoon wounds were probably much more frequent than bayonet injuries, which were rarely seen, really. So those were the most common injuries where they occurred. Survival depended very much on getting through bleeding on the battlefield. And many men bled out because there just weren't the staff to remove them. And when you got to your surgeon on the front line, he would bandage, dress, try and stop bleeding, and send back to a regimental field hospital and so forth. And the field hospitals and general hospitals were where the big operations were carried out: trepanning, removal of a joint or a limb, disarticulations, and so forth. And general support was with the antiphlogistic regimen: bleeding, low diet, catharsis, and emesis. This was believed to reduce the chance of infection. There's no logic to it whatsoever. And it was a heritage of the humoral theory, I suppose.
Yeah, I was going to say, this is sort of still at the tail end of the age of the humours, isn't it? So that awareness of bacteria as a means of spreading infection just isn't there. When it comes to that survival prospect, I just want to stay with infection for a moment. We have this perception that infection was absolutely rife. Is there sort of this growing awareness that there are methods you can use? I think in the past we've talked about things like separating patients who have a particular type of ailment as a means of trying to stop that spread. Can you just sort of talk us through that a little bit?
It's a very good question. There isn't a lot written on this, but there was one lovely trial, and I've forgotten the reference, where they put uninfected soldiers next to infected ones and saw that the uninfected one, that was totally unethical, got infected. So they knew there was something in the air or in the fomites or whatever one surgeon treated one patient, went on, he could transmit the infection. But of course, the germ theory just wasn't there yet. Pasteur came around in the 1860s. And Lister followed. So de rigueur infection, they did know that it was transmissible, and they would often separate surgically wounded men from diseased men. And that's very important too. And I mean, in McGregor in Egypt, put sentries around people he thought were going to get the plague and prevented anyone going near them. And these little flashes of inspiration were not generally well known. And obviously there is such a diverse spread of different types of disease that you can't really make general rules. But there were examples of the understanding of transmission, although the mechanism wasn't known.
And just very briefly, in terms of that immediate care, we talked about how the debate about triage and your research suggesting that actually such a thing doesn't exist. At the point of taking a wound, is there much awareness of what today we might term first aid? These ideas that you might tie off a limb that's taken a wound, you might compress a wound. Is there any awareness of those kinds of methods? Do we see that being implemented?
Oh, yeah. I mean, splinting a fracture with very badly designed splints was done. Dressing a wound to stop bleeding, putting a tourniquet on, although you had to watch how long you left the tourniquet on, was practiced, and they knew that. So yes, I mean, stopping bleeding if you could, but obviously any intracavity bleeding or intracranial bleeding on the field was just, I mean, there were overwhelming numbers of casualties, that, and there's no force then that could have cleared them and triaged them and brought them in. So to get to hospital was a huge survival indicator, actually.
Mick Crumplin, it's been a fascinating discussion. Folks, this has been Mick Crumplin, retired surgeon and historian and author of Men of Steel, Surgery in the Napoleonic Wars, and co-author of Waterloo After the Glory. Mick, thank you so much for your time here on Waterloo Live.
Thank you, Zach.